and I'd like to welcome everyone to the second annual Within Summit. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I'd like to introduce you to Catherine and Alicia. Alicia is a licensed marriage and family therapist, certified eating disorder specialist, supervisor, and a certified mindfulness instructor. Alicia has 25 years of experience in behavioral health, working with children and adolescents, adults, and families. She has focused most of her career on working exclusively with eating disorders, instrumental in launching eating disorder programs in Florida and Virginia. She has specialized training in cognitive behavioral therapy, dialect behavioral therapy, family-based treatment, mindfulness. She has provided supervision and training for those pursuing state licenses in addition to IEDP certification. She is the past president of the Richmond IAEDP chapter, served on the IAEDP National Board as a chapter representative in 2021, and volunteers with the Eating Disorder Coalition to support advocacy efforts. Additionally, she has presented at local and national conferences. I would also like to introduce you to Catherine. Catherine is a registered dietitian, nutritionist, and a certified specialist in pediatric nutrition. She earned her Bachelor of Science in Nutritional Science and completed her dietetic internship at Texas Christian University. She has over 10 years of experience in pediatric and adult clinical nutrition and specialties in eating disorders and gastrointestinal disease. She strives to provide individualized and quality care for her clients struggling with eating disorders. Welcome, Catherine and Alicia. Before we kick things off, I do have some general things to go over in regards to the CEU credits. Evaluations will be sent to your email that you use to register for the presentation. Once the evaluation is complete, you will receive a link to download your CE certificate. Please utilize your CE Go dashboard for all things CE related. A video of the presentation will also be posted after the video is finished. You will not get credit, however, for just watching the video. You must attend the presentation live in order to receive the credit. To access the video or your certificate, please utilize your CE Go dashboard. If there are any technological issues that do arise and you need to change devices, you will get credit for being here today. Also, if there's any issues, I will provide my email in the chat, as well as Jamie Singletary's, and the CE Go support button will also be there as well in case you need to contact CE Go directly. Again, I want to welcome Alicia and Catherine for presenting on ARFID care in the virtual world today, and we're so grateful to have you both.
Great. Thank you so much, Ashley, for that warm introduction. And good morning, afternoon, and evening to all of you, depending on where you are joining us from today. Catherine is going to drive the slides for us as well. So let's take a look at our objectives for today and how we are going to spend our time. As I was preparing for this presentation this morning, I was also thinking about what a gift it is to really be able to present on the last day of a conference. It really gives us an opportunity to take what we have learned throughout the week and to be able to connect some of the dots with what we are going to discuss today. We've heard a lot over the last couple of days about attunement. We've also heard about lived experiences. And we've really been afforded a great opportunity here at Within to take into account things such as our clients' lived experiences to be able to build a robust ARFID program for our clients. We also know that given the limited research regarding ARFID, especially with our adult population, it really takes all of us working together in a collaborative community to share what is working and what is not working, especially taking into account feedback from our clients, again, to build an effective program. Many of you heard Dr. Wendy speak yesterday about how clients' lived experience, as well as feedback that she has received over the years, has also been instrumental in helping her to build world-class eating disorder programs. Some of the literature that we reviewed also emphasized the need to flex our creative muscles when it comes to developing ongoing interventions, especially for the ARFID population. There was also one study, for instance, that utilized natural language processing, or NLP. And this classified feeding strategies looking at childhood experiences of adult clients with ARFID, really again emphasizing the importance of turning to those with lived experience. So today we're going to spend our time looking at strategies that can be used in the treatment of ARFID in a virtual setting. We're going to demonstrate ways to utilize a food hierarchy, also in the assessment of ARFID. And we're going to spend our time specifying treatment interventions, including but not limited to exposures, and how to implement these at higher levels of care in the virtual space. All right, let's take a look at the DSM-5 criteria when it comes to ARFID. So the ARFID diagnosis is really not a new diagnosis, as it replaced the DSM-4 diagnosis of feeding disorders of early infancy or childhood. What it did take into account or remove was the age of onset criterion, which was previously limited to those under the age of 6. The weight loss criterion was also removed, providing a diagnostic framework for those with feeding disorders who do not exhibit low weight. It also acknowledged psychosocial stressors and physiological consequences, such as nutritional deficiencies, specifically around failure to grow consistently due to limited safe foods. And really the big takeaway here is that the DSM-5 moved the diagnosis from a feeding disorder to an eating disorder, which did provide more treatment options for these clients. Let's take a look at the epidemiology of ARFID. In one study, it was estimated that 5 to 14% of patients in a pediatric inpatient eating disorder program were diagnosed with ARFID. We also know that as high as 22.5% of patients in a pediatric day treatment program were diagnosed with ARFID. We also see approximately 20 to 30% of ARFID cases as males. And in one setting, approximately 67% of the clients diagnosed with ARFID were male. We generally see a 2-to-1 male to female ratio. Comorbid psychiatric symptoms, in addition to the medical symptoms that we will review a little bit later on in today's presentation. We also know that children with autism are more likely to develop ARFID, and those with anxiety disorders are also at a higher risk of developing ARFID. Clients may be responding to fears related to contamination, abdominal pain, or perhaps seeing another person vomit or choke. The client may also experience nausea or difficulty swallowing. Clients may be exhibiting one of the aforementioned maintaining mechanisms or somatic concerns, perhaps for a variety of reasons. This could be a stress or trauma response. The fears around contamination could be due to messages perhaps that they received in childhood. They may restrict to avoid experiencing an aversive event again. And they may also restrict to avoid unwanted tastes or textures. We also do not want to lose sight of the fact that clients with ARFID may also be adults. Over 50% of the clients with ARFID that we currently treat at Within Health are adults. Let's take a look also at some of the psychological concerns. As I mentioned before, the DSM-5 highlights marked interference with psychosocial functioning as one of the criterion for a diagnosis with ARFID. And this really reminds us to consider concerns around psychosocial interference, as there are instances in which some of this criteria may be primary, again, as the client may be meeting nutritional or energy needs and are of normal or slightly above normal weight. Clients may be experiencing the inability to participate in normal social activities because of the avoidance or the restriction that we see with ARFID. There may be isolation due to fear of eating in public. They may have difficulties engaging in normal age-appropriate activities, such as going to school, socializing with peers, or perhaps even holding down a job. Friends and family may have difficulties establishing and maintaining relationships due to difficulties managing some of the eating situations. We also want to look at the family and perhaps how the family or loved ones in the home setting may be providing accommodations to foods, such as participating and purchasing foods from specific grocery stores or restaurants, and really how they engage with the client. It does perhaps make disruption to family and relation and social functioning, and we may also see a lack of self-esteem. Let's take a look at multidisciplinary assessment. It really does take a village and a number of multidisciplinary team providers to provide a thorough assessment when it comes to the treatment of ARFID. In a few slides, Catherine will highlight medical and nutritional assessment. In my role, however, as a therapist, I would focus on providing a thorough biopsychosocial evaluation. I would want to take into account the extent to which the avoidant or restrictive eating interferes with the client's activities of daily living, education, work, in addition to evaluating other co-occurring disorders, such as anxiety, and the extent to which those may be barriers. Assessment should also take into consideration the maintaining mechanisms for ARFID that we saw previously on another slide, and any behaviors that might be unintentionally reinforcing the client's symptoms. We also want to engage in a thorough assessment of the home environment. Again, as we mentioned on the previous slide, the family may be providing accommodations to provide foods from specific grocery stores or restaurants that may interfere with increasing the client's variety when it comes to food. The multidisciplinary team may also include specialists for more complex ARFID presentations. For younger clients, we often involve additional disciplines when the case is more severe or medically complex. For instance, we may utilize a speech and language pathologist for oral sensory motor concerns when the client has difficulties with texture progression or swallowing, for instance. We may also utilize an occupational therapist when there's difficulty processing sensory input or difficulties with activities of daily living. In addition to a thorough clinical evaluation, we also want to supplement our assessment with standardized measures. So first, we want to look at some of the structured interviews that we may have the potential to utilize. The EDA-5 for adults or youth is designed to assist in the assessment of a feeding or eating disorder. The youth version is for ages 8 to 14. This also aligns with the diagnostic criteria in the DSM-5. The structured clinical interview for the DSM-5 also looks at various comorbidities in addition to eating disorder symptoms and can assist us with ruling out other eating disorders. The PICA ARFID rumination disorder interview, otherwise known as the PARTY, has 4 versions. This is quite extensive in length. There is a version for parents and caregivers for those ages 2 to 3. There's one for ages 4 plus. There's one for children ages 8 to 13 and adolescents. And then there's also one for ages 14 plus, which we would also utilize for our adult population. The PARTY looks not only at ARFID, but also the severity, and also looks to rule out other eating disorders. We also have self-report measures that can be utilized. I want to focus specifically on the NIAS, which is the 9-item avoidant restrictive food intake disorder screen. This contains, very simply, 9 items, hence the name. Contains a severity assessment that looks at eating restrictions related, for instance, to picky eating, poor appetite, and fear of aversive consequences. So this aligns really nicely with the DSM-5 criteria for ARFID. There's also a parent version of this assessment and one that we also utilized here at Within Health. And then the state trait anxiety inventory also looks at anxiety predisposition. As we mentioned earlier, many clients with ARFID do have anxiety, which at times prevents them from engaging in some of the food exposures, which we'll talk about a little bit later. And then these are the maintaining factors. I also like to call them drivers that we spoke about a little bit earlier today, or that you saw in one of the prior slides. So again, we talked about some of the structured interviews that can be used in the assessment of ARFID. The party, for instance, is really designed to assist the therapist in conceptualizing the symptoms in this three-dimensional space. So again, the fear of aversive consequences, limited hunger and interest in food, and heightened sensitivity to the sensory experience of eating, resulting in limited intake. We know that ARFID is an eating disorder also of restriction, where there is a lack of interest reinforced by the restriction over time. We also know that selective eating may be maintained by disgust or disgust sensitivity, and the fear of aversive consequences, such as physical problems, including physical or GI pain, abdominal pain, anxiety perhaps around a severe allergic reaction, or worries around choking or vomiting or contamination that may also limit a client's ability to engage in food exposures. Treatment can be individualized to target the client's maintaining factor. We also know that there is the possibility of an overlap of some of these presentations. So we really do need to work together as a team to prioritize which maintaining factor are we going to target first in our treatment interventions. The CBT-AR manual really does a nice job of outlining some of the various interventions that we can use that are also dependent on the maintaining driver.
Next, we'll hop into the nutrition assessment. I always like to think of the nutrition assessment as an opportunity to really get some more information regarding the ARFID presentation and how it has physically affected the client. And I will highlight a couple things that are specific to the ARFID population in particular when we're doing the nutrition assessment. So of course, with all of our clients, we always start with the anthropometrics, assess their height, weight. I always love to pull in growth charts whenever possible. It's always nice when we have a nice extensive history of the growth charts as well, so that we can really assess, where are we really trying to go when we think of weight restoration or weight maintenance, depending on the client. I'm going to skip over history of eating patterns and come back to that one. GI issues that might be influencing intake. So like Alicia just said, there might be a fear of some consequences, and some of those consequences might be GI related. So always taking a look to see where we're at GI wise, and if this client has ever had like a GI workup with a GI specialist as well. Hydration. So many clients who are restricting food intake tend to restrict their fluids as well. So we always want to assess where they might be at hydration wise. Vitamin and mineral deficiencies. So this is done through laboratory values that we, of course, work closely with our medical providers to obtain, but then also what we call a nutrition-focused physical exam, which I'll get into a little bit more, but gives the dietitian an opportunity to really assess malnutrition and vitamin and mineral needs a little bit more. Malnutrition criteria assessment. So really taking a closer look on, has this client had any weight loss? Do they have a low BMI? Are we not meeting our estimated nutritional needs? Why is malnutrition criteria important? So our malnutrition criteria is important because malnutrition is a very good indicator, of how someone may heal, how someone may heal from a procedure, heal from a surgery, defend themselves against different diseases. So very important that we're taking note of malnutrition. And then two things that are particular to the ARFID population in particular is the eating history pattern and the hierarchy of foods. So history of eating patterns. So I always like to do a nice in-depth history of eating whenever this client was an infant or a toddler, because I find this can provide a really good context of when some of these eating patterns may have initially started. I may hear a client and mom chimes in saying that, they had terrible reflux when they were a baby. And this led to them being pretty picky when they were younger. And then they kind of grew out of it. And then we started seeing some of these behaviors again a little bit later. So I like to use that as an opportunity to try to connect the dots a little bit more. And then also the hierarchy of foods. So definitely an important part of the nutrition assessment, because it really provides a really nice history of where the client might be at right now nutritionally, and where were things kind of in the past, and where might we make some goals going further. So definitely an important part of that nutrition assessment that is a little bit more unique to this ARFID population and something that we might do earlier on. So nutrient deficiencies. So as I just said, many clients with ARFID tend to have a pretty limited intake of foods. One thing that's important to be cognizant of is with our ARFID population, many times we might see some vitamin or mineral deficiencies without seeing those classic signs of malnutrition. So meaning low weight or weight loss, lower fat stores. Like we may not be seeing some of those classic signs of malnutrition, and there might be some vitamin and mineral deficiencies. So here kind of list out the most common ones that we tend to see with our ARFID population. One important thing to note is sometimes our medical providers are pretty routinely checking some of these values. So calcium, sometimes folate, iron, a lot of times vitamin D, those are checked many times on our classic lab panels, but we're not always checking for vitamin A. We're not always checking for vitamin K. We're not always checking for zinc or vitamin C. So big things to kind of take note of that we might not have a clear picture of right away. And that is where our nutrition-focused physical exam comes into play. So a nutrition-focused physical exam is a assessment that a dietitian may do to assess physically signs of malnutrition. So like I said, we might be testing grip strength. We might be testing, palpating on like different fat stores or assessing for edema. With that, our body shows when we're deficient in certain vitamins and minerals. And interestingly, a lot of those common nutrient deficiencies that I just outlined in the past slide are ones that we can see virtually pretty readily available. So I can see someone's hands pretty easily. Iron deficiency, zinc deficiency, I can see that in their hands. I am always seeing my client's face, so I can see those signs of vitamin D deficiency. I can see those signs of folate deficiency with those cracks in their mouth. Essential fatty acid deficiency. So that would present with scaly, dry skin. And our essential fatty acids provide the availability for us to absorb our fat-soluble vitamins. So when we are deficient in essential fatty acids, we're not as able to absorb the vitamin A, the vitamin D, the vitamin K that we just listed on the last slide of those common nutrient deficiencies. So I challenge all the dietitians to take that extra step, even if you are working virtually, to assess the client for some of these vitamin and mineral deficiencies that might be right there in front of us. And then the hierarchy of foods. So, like I said, this is really an assessment of the client's current intake and a tool to organize opportunities for exposure. There are tons and tons and tons of different ways of doing the hierarchy of foods, depending on what the client's needs are. For some people, we like to do kind of like a red, yellow, green. So red would be those foods that are foods that we can't imagine eating. They're so unsafe right now. Our yellow foods are ones that we might be interested in eating, but aren't quite there yet. And our green foods are ones that are safe now and we'll eat now. There is a free one available in the CBT-AR workbook that you can get online. So I always like pointing toward that tool because I think that has a lot of great information and tools that we can use with our clients. Here at Within Health, we tend to use the food preference list, which is similar to the one that's in the Conquering Picky Eating workbook, if anyone has picked that up before, but it's an extensive descriptive tool to assess that hierarchy of foods. So really breaks down foods in a bunch of different food groups and kind of goes through foods that we're eating right now and are safe to us, foods that we used to eat but aren't safe anymore, foods that we can never imagine eating, foods that we've never eaten before. So really breaks things down so we can get a nice collective history of where we're at and where we might be going in terms of their goals. I like to do the hierarchy of foods in, like I said, different ways depending on the client's needs. Sometimes they do best if we do it together, one-on-one in our nutrition session. We also have fabulous care partners that meet with our clients each week and work on experiential opportunities, reflective opportunities, really support them in however they're really needing it in that moment. So sometimes they'll work on this together, or some clients prefer to work on the food preference list on their own and then bring it back to session and we go through it together and really use it as a tool of how we're going to really work on increasing food acceptance. And some goals for treatment. So really, first and foremost, we work on achieving or maintaining a healthy weight, depending on whatever that client may need, correcting nutritional deficiencies. Then we really work on eating foods from each of the 5 basic food groups and expanding the repertoire. Feeling more comfortable in social situations that involve food. And then lastly, engage in eating experiences that are important to the client's overall well-being. So that's where the client's treatment goals really come into play. You know, what are the eating experiences that the client really wants to be able to get out of their time in treatment? What is going to be most beneficial to them, not only in programming and in treatment, but what can we really take as experiences to their everyday life and what is going to provide them with more opportunities overall.
All right, let's talk about some of the therapeutic interventions. First and foremost, we talked earlier that a speech and language pathologist or an occupational therapist may be indicated for a particular client. So we may want to have an assessment provided by an SLP or an OT, really to determine the client's appropriateness for exposure therapy, especially in the event that they're having some swallowing difficulties. One of the benefits of working, especially in a program like Within, virtually and at a higher level of care, is that we have a multidisciplinary team here ready to engage with our clients. We're going to specifically talk a little bit later on in the presentation about how we are treating ARFID here at Within and some of the modalities that we are offering. For instance, we provide DBT and CBT, and utilizing this modality in the treatment of ARFID is really to better help our clients understand their emotions and what their emotions are telling them to do. Very often for clients who are feeling anxious as they're entering exposure, there's usually some negative self-talk that is associated. So again, our goal here is to help the client challenge those unhelpful thoughts and learn some more adaptive skills. When it comes to socialization, we want to provide increased opportunities to give our clients the opportunities to try some of the new skills that they are learning in treatment out in the real world. So Catherine mentioned our fabulous care partners, and our care partners may assign the client some experiential opportunities that they can then engage in as well to be able to practice those skills in real time. We want to utilize family interventions. Again, we want to assist the family in reducing some of those accommodations that may be reinforcing the behavior that we talked about earlier. And then exposures we're going to touch on very soon here. We also recognize that providers really, when it comes to the treatment of ARFID, are having to adapt some of the existing treatments, taking into account what we know about ARFID, really to develop some creative interventions due to some of the limited literature out there. And that's kind of the fun part, is getting to take what we know and also being able to talk to our clients, getting their feedback, finding out what's working, what's not working, and then from there coming together as a team to develop some of those creative interventions.
Then we jump into nutrition goals for ARFID treatment. I love this image from the Ellen Satter Institute because I feel like it gives just a really clear picture of how we kind of work our way through treatment. There is so much nutrition information on social media, in maybe our clients like health classes among friends, and it can put a lot of unnecessary pressure and confusion to our clients to maybe include certain foods that maybe they're not quite ready for. So I love using this image so my clients can really see how we're going to work our way through. At the base of it, we want to get enough food. That's what we're going to work on, number one. And then we're going to work our way up and work on including some more foods that are readily available, easy to access. Then we might really be working a little bit more on taste, right? Like, what foods are we really enjoying? What foods are bringing some enjoyment to our lives and bringing some more opportunities to our day-to-day life. And then lastly, more of those instrumental kind of foods. So kind of going back to the nutritional assessment and vitamin and mineral needs, like what things are we maybe not getting from our current intake that we can do some exposures along as well to really expand where we're at. So like I said, I love this image because I think it just provides a lot of clarity of where we're going in treatment. And like I said, at the base of everything, we, number one, want to make sure that our clients are meeting their needs. Number one, are we getting enough fluid? Are we getting enough energy? I like this picture over here to the right of the plate of chicken nuggets. because that's where we may be meeting our clients. Number one, we just want to make sure we're getting enough. So maybe that looks like we're increasing the portions of our safe foods and providing some support to be able to increase those portions. Maybe we're increasing our intervals of eating occasions. So maybe this person is eating once or twice a day, and we're encouraging them to include some snacks, include breakfast in their day. Maybe we might be using some nutritional supplements temporarily just to, number one, make sure that we're getting enough energy in, adequate hydration. So, number one, are we getting enough fluids in? And sometimes this takes some creativity too. Not everyone likes water. So are we, trying some different beverages or foods that contain some fluid so that we can make sure that our clients are meeting their hydration goals? And then lastly, based on our nutrition-focused physical exam and those laboratory values, we may, between a consultation with the medical provider, recommend some vitamin and mineral supplements to make sure that we're meeting our vitamin mineral needs as well. And then we move into what's missing on my plate. So this is where the hierarchy of foods really comes into play more that we started in that nutrition assessment. So here's where we really take that hierarchy of foods and put it to practice. We assess where we're at with those safe foods, and then we really use our plates. So I love this visual over here to the right. Here at Within Health, we use our kind of version of the plate by plate method. So you'll see this is called our Thrive plate. And about a third of the plate is grains, a third of a plate protein, third of our plate fruits or vegetables. And then we make sure that we have a fat source component and a dairy or a beverage, depending on the client's needs. But we really use this plate as our visual to, number one, assess where we're going with some of our exposures, and then also provides a clear picture for the client, for our care partners, for us as the dietitians, to really decide what the client may be needing. Are there nutritionally dense foods that we might need to be adding to our plate to really meet our estimated needs at this time? Are we missing some crucial macronutrients at this time? Are there micronutrients not present that maybe we can add in? I highlighted the last one here though, because this is always the most fun part for me with working with ARFID clients is really thinking what is going to be most enriching to my client's life outside of treatment. What exposures are really going to provide some more opportunities for them that maybe the ARFID has really been holding them back from. That's where I really like to focus a lot of our exposures when we're able to, so that clients are able to experience some of those life experiences that the ARFID has really been a barrier from. Exposure therapy. So I think both Alicia and I are going to jump in on this one. But just to kind of give a definition, exposure therapy is an evidence-based treatment modality that treats phobias, fears, anxieties, which breaks the cycle of fear and gradually exposes the client to the fear in a controlled, monitored manner. And this can look very different. On the next slide, I'll go into a little bit more in depth of the different ways we can do some exposure therapy with food, but this can involve from sitting with the food to eating the food, a wide variety of ways we can incorporate exposure therapy and use the SUD scale. So really the SUD scale is an assessment of the anxiety throughout the exposure.
I also like to think of the SUD scale as a way to take the client's temperature. So going into an exposure, we want to know, where is their anxiety on this scale? And knowing that ahead of time can also assist us with intervening at the very start of the exposure. So for instance, some things I've had clients do before are, especially if they're, a child or an adolescent, and they've also got a lot of energy as part of their anxiety, I may have them, kind of do some arm circles. I may have them do a brief meditation as well to really decrease some of that anxiety going into the exposure. We also want to take their temperature at various intervals as we progress throughout the exposure. We also want to take their temperature at the very end. But again, knowing that temperature at the outset can really help us to conceptualize what will change the temperature. We really want that number to go down to 0 at the end of the exposure. We can also do things such as practice distraction throughout the exposure. We can sing, we can play some soft music in the background. These are also all things that we want to review with parents and caregivers who may be engaging in some of the exposures outside of treatment in the home setting as well, so that they know what will be most helpful for their loved one.
And just wanted to provide a little bit more context of how we can actually start incorporating some of these new foods. So one tactic is what's called food chaining. So this is kind of thinking how we can incrementally go from what is considered our safe food to a food that might feel unsafe. So I always think about like the classic ones of like a chicken nugget to a chicken breast, or a French fry to a sweet potato or a baked potato. How can we incrementally, maybe go from a chicken nugget from McDonald's, and then maybe we're doing a chicken tender, and then maybe we're, making our own fried chicken at home, and then maybe we're doing a little bit lighter breading. And then same thing with like the French fry. How can we go from like that McDonald's French fry to maybe making a French fry at home, to maybe trying like some diced potatoes? So how can we gradually go from one food to a food that's safe to a food that feels unsafe? Let's jump back. Increasing quantity of the preferred foods and fading in small amounts of those novel foods. So this may be, we start with that plate of chicken nuggets that we saw on the last screen, and we're adding like 1 or 2 pieces of broccoli on there, if that might be a food that's fearful for them, and gradually trying to increase some more of those novel foods. And just some different ways of incorporating new foods. Can we add spices? Can we add sprinkles? Can we add condiments? How can we really switch up that presentation as we're including more foods to really expose them to different things in a way that feels more available to them?
CBT-AR is a manualized treatment utilized on an outpatient basis for the treatment of ARFID. This was developed by Jennifer Thomas and Cameron Eddy out of Cambridge, Massachusetts. This modality is also used to inform ARFID treatment at higher levels of care. When it's utilized on an outpatient basis, it's approximately 20 to 30 sessions. The sessions would be at the higher number, especially if the client is needing to weight restore. It's also broken down by 4 modules, 2 focus on psychoeducation, 1 on psychoeducation about ARFID, the other on psychoeducation, for instance, about nutrition deficiencies. Section 3 focuses on utilizing the modules based on the drivers that we spoke about earlier. And then 4 is a relapse prevention plan. We have 2 formats. So we have the family-supported CBT-AR. That's typically used for clients under the age of 16. It may also be used for those between the ages of 16 and 17, especially if those clients need weight restoration. There's also an individual form for those ages 16 and up. And also just want to mention that this is a modality also used for adults as well. In a study evaluating CBT-AR for adults, 18 foods were added and 47% no longer met criteria for ARFID at the end of treatment. So that was really positive to hear. One of the things that I really like about this model as well is at the end of session, the therapist utilizes a session-by-session rating scale. So there is an opportunity to really measure the client's progress at the end of each session or at the end of each exposure. With psychoeducation really being a hallmark of CBT-AR, this is really where we get an opportunity to discuss our conceptualizations with the client. We get to provide psychoeducation on ARFID, the nutritional deficiencies, the maintaining mechanisms. We also get to assess family dynamics and responses. And we get to talk about the different treatment approaches and the treatment plan that we will utilize for the client. We also want to help clients and their loved ones understand that there may be some underlying biological traits in which their eating practices make sense. The client may be restricting or avoiding food to avoid an aversive response. I think that probably makes sense for a lot of us. They may be avoiding or restricting food to avoid gastrointestinal pain. We also don't want to assume that clients and loved ones know about ARFID really due to it being a newer diagnosis in our diagnostic repertoire. There are also some fabulous infographics in the ARFID workbook. I can be sure at the end of this, hopefully, to grab the link if I can find it and drop it in the chat. And then psychoeducation also supports treatment engagement, as well as assists with increasing rapport. We also want to look at the family accommodations that might reinforce the client's negative beliefs when it comes to food. The accommodations might also be decreasing the client's motivation for treatment as well. Parental pressure might also decrease client intake and may increase some of the food aversions. So as you can see, there's a lot that we need to cover in the way of psychoeducation. We can also educate on some of the comorbidities and some of the modifications that we're able to make depending on the diagnosis. If this is a child or adolescent, we can also talk about utilizing positive reinforcement. We might look at utilizing something such as a monetary reward system, a token economy system centered around a monetary reward, for instance, for completion, a toy, time on electronics, which I know many parents are already trying to move away from. And that will certainly differ based on the client and the home setting. So what does support look like for parents, loved ones, supporters? First and foremost, we want to assess the home setting. And that's one of the beautiful things about the work that we do here with Within is we're able to be literally in the home setting, as you've heard Dr. Wendy talk about. We want to assess food rules. We want to look at habits and various practices in the family. This will really assist the parents with their at-home practice. We can teach the parents creative ways to engage in some of the exposures at home, really outside of programming time. In one study I had taken a look at, parents referred to the exposures as food experiments, and the children got to be food scientists as well. And that really allowed the clients to embrace a sense of curiosity when they were trying new foods. We talked a little bit before about the reward system for the client engaging in successful food exposures. The therapist will work with the family on establishing a reward system for the exposures, and a non-food reward will be provided for each successful food exposure. And that will be a reward based on the parents' choosing. We also want to look at some of the language and coach the parents on language to use during food exposures. We've had some clients say that maybe they feel that parents are utilizing language that feels maybe a little bit forceful during exposure time as well. So we really want to look at what's helpful, what's not helpful. Rebecca Brum spoke about the validation sequence yesterday from EFFT. That's something that we can also teach the parents how to use, how to be validating in that experience. We also want to teach parents about positive mealtime hygiene, and we want to decrease distractions as much as possible. Treatment adaptations. Hopefully many of you had an opportunity to attend Brittany Ashmore's talk yesterday, where she spoke a little bit about accommodations that are made for autistic individuals in eating disorders care. Adaptations may include things such as frequent breaks, shorter sessions. Here at Within, we have programming that starts at 8 o'clock in the morning and goes all the way up until 10 o'clock in the evening. So we might have longer breaks within the client's schedule. We have some great infographics that we can use, visual cues that can assist with psychoeducation. We can really break down directions that we're using with our clients as well. If the client has a substance use disorder or even active or passive suicidal ideation, we'd certainly want to make sure that those issues are treated first prior to coming to Within and engaging in our ARFID program. And then the National Institute for Health and Care Excellence also has some wonderful guidelines when it comes to treating individuals with eating disorders along with specific comorbidities. And treatment at higher levels of care, in some of the literature that we looked at, there really were some benefits of treating ARFID at higher levels of care because we have more frequent touch points. We're also able to offer some creative groups. We've also heard a lot this week about building this sense of community. We have more group opportunities for our parents and our loved ones. We're able to provide some separate skills groups, weekend planning sessions. And what we saw when it came to treating clients with ARFID at higher levels of care is that 79.2% of those clients remained out of the hospital at a 2-year follow-up. Just in the interest of time, I'm not going to spend too much on the next couple of slides. We did see a lot of pros when it came to the treatment of feeding disorders, especially virtually. And again, one of the hallmarks here of Within that you've heard about throughout the week is we do provide effective treatment at home, and we can also provide effective treatment in the home setting for ARFID. By being able to go into the home with the client, with the family, with the loved ones, we're able to assist with exposures in the home in the place where the exposures will be provided. And we also know that food is more readily available in the home. And then let's talk a little bit about the cons. We also know exposures are not the same every day. We also saw that clients being treated for ARFID were sometimes distracted by their image on the screen, which prevented them from engaging in some of the treatment options and some of the exposures. So that may promote a decrease in appropriate mealtime behavior. So how are we doing? We've done a lot of fabulous things here at Within, and putting this presentation together really allowed both Catherine and myself to take a look at everything that we have implemented here for the treatment of ARFID. We've also been able to build a great community. We've heard a lot about that this week as well. We have a parent loved one support group that we have on Tuesday evenings at 7 p.m. We're also really able to engage our care partners in one-to-one sessions to focus on experiential opportunities that might even include experientials down the road, such as gardening, which helps to make food such a pleasurable experience for our clients. We can also create a positive sensory environment in the home setting to promote a calm environment to really support those exposure opportunities. We can also engage in, the food scientists that we spoke about a little bit earlier. So we have a lot of flexibility to do some creative things to really meet our clients where they are.
I agree, Alicia. It's been so much fun to put together this presentation and really see how we've gone, especially in our task force, from researching and thinking about how we may have previously done things in person and how we've really brought a lot of these things into the virtual world. So specifically, individualized nutrition support is something that we really value here at Within. One of them being we have ARFID support meals with trained care partners. So we do have meals that are specifically for our ARFID clients, and provide opportunities for exposures and distraction and different sensory opportunities that maybe you wouldn't see in some of the traditional eating disorder treatment available. We provide one-to-one exposures with dietitians at least twice a week when that time is available. Two of the coolest things I think are the next 2 points. So we do have some wonderful food specialists on our team that work with the client on ordering food and delivering it into their home, depending on their food preferences and, where they might be at with exposures. We have 3 amazing chefs that work for Within, and they do one-on-one cooking exposures. So when we talked previously about, sitting with the food or cutting the food or smelling the food, a lot of those opportunities are available in that cooking experience that they can do with the chef. And then last thing, we do have meal logging built into our app. So the dietitian can review, how some of these exposures might be going throughout the week outside of programming, and also provide some support and guidance on some of these exposures between those session times that we might be seeing a client. In the interest of time, I'm going to quickly go through our movement protocol, but didn't want to go without highlighting our amazing movement specialist and our movement protocol. So all of our clients at Within Health do have a one-on-one movement assessment. So not only are we focusing on how we are providing support for the eating disorder, but also how movement might intersect with that. So you can see we have some different levels when it comes to movement, and that provides some clarity for the client, for myself as the dietitian, our team that does all the scheduling, our movement specialist, what the client should really be focusing on depending on the client's medical, physical needs at that time. Is this someone that mainly is focusing more on restoring their body, letting their body rest, all the way up to, we have some people that are professional, college, high school athletes, and movement might look a little bit different, and that may intersect with where their nutrition plan is. So just wanted to highlight how movement is also part of the process as well. And creating a sensory environment. So this is more just some tips, and I know Alicia went through some as well, but really individual to whatever is best for the client. These are just some suggestions. Do we need to be sitting down for the meals? What distractions are helpful and supportive to the meal experience? Should we turn on some music? Should we have an ice pack around? Should we have a heating pad around? What the family education and division of responsibility and don't yuck my yum. So really, what things should we maybe avoid discussing at mealtime? Or what support is helpful from family and what things are maybe hindering a little bit. Did you have anything else to add, Alicia?
No. Perfect. That's great. And then just lastly, we'll end on this slide. We had a case study for you, and I know we're not going to have time to get over to that today. We have an ARFID task force that meets on a regular basis, and we've put into place some things to support our team as well, such as a case consultation group. We've done various trainings. Again, we involve our care partners, but, I think the overall theme today is that we've just had a really fun time building this program, taking into account not only some of the research, but also our clients' lived experience as well as their ongoing feedback. So thank you all for coming out today. Catherine, if you want to jump over to the thank you slide, that also provides our email should you have any further questions or want any of the additional resources that we've mentioned today.
Wonderful. Thank you, Catherine. Thank you, Alicia, for such an insightful presentation on ARFID and how we can further advance our skills. I just want to thank everybody else for joining our space today and for really creating a cohesive environment together. I also want to mention we still have a few events this afternoon for Within Summit. Feel free to check those out and get a last few minute great summit talks that we have scheduled for this afternoon. And again, I want to thank Alicia and Catherine for being in the space today and providing such great information for all of us.